All right, I think we'll get started, although I know we're not at quorum, but 3:32, so if I'm here on time, I'm obligated, so we're gonna start the live stream and begin our Board of Health meeting. So welcome, everybody.
I just got a text from Dr. Clark that she is just finishing her last meeting and on her way now. She sends her apologies.
So first on the agenda is introductions and general announcements. So I just wanted to officially welcome Terry Lynn. She is our new executive administrative assistant. What's the right word? Secretary. No. Taking notes for the board and keeping us in order and all things board like. So thank you for your help. And she and Megan put the minutes together and got us prepped for today. I know we can talk about later, but we can talk about RSVPs if that's an official thing or not an official thing, but we're officially recording. We do have some guests in the room, so let's introduce our guests today. Go ahead.
Hi, I'm Dr. Shannon Coverly Thompson. I'm the new executive director for the Council of Agency Executives. So I'm here to listen and learn, and want a list of our members or anything about our council.
Wonderful, thank you. And
hi, I'm Elizabeth Butcher. I work in DEI for the county. I'm the staff development and AD manager. I visited last month as well, so I just appreciate you allowing me to come. And I'm intensely interested in the things that are going on in terms of public health here in the county. Thank you.
Great. Thank you for saying DEI in public.
Yeah, right.
We want to do that. We are on video, aren't we? But thank you for that. So our next order of business is the approval of the minutes, but we have 1, 2, 3, 4, 5, 6 out of 11. So that's quorum, right? Yeah. So those of you that are here, so 7 and 8. Yay! All 7. Welcome.
I do.
Brendan and Dr. Acock have joined us. And Miguel, yeah, I know. Thanks. Welcome. Yeah, right in front of the camera. There you go. Hi, Sarah. Perfect. Here you go. Okay. I did it. Dr. McIntyre. Yeah, another seat for her. So we're reviewing the minutes. I just had a question. It says Bill Hunt was in attendance, but I don't think he's with us anymore. I mean, not in. I think you're correct. He's still alive, just not part of the board, so we can take him off. Please. Are there any other edits to the minutes? Thank you. One second. Great. Thank you, Albert and Emma. All in favor of approving the minutes from our last meeting, say aye. Aye. All opposed? And abstentions? Great, the minutes are approved. So we can take draft off and that's official. Thank you very much. All right. We are now onto the commissioner report, and Mari is in the internet somewhere, so she's home with the sick kid. If you can hear us, can you take over?
Yes. Okay. Good afternoon, everyone. Unfortunately, we have now had a second pediatric measles death in the outbreak in Texas, not here. This was an otherwise healthy but completely unvaccinated child. We here in Monroe County are actively making preparations for the possibility, I don't know, maybe I should say the eventuality of a case here in the county. Our last case was in 2019. It was in the Ukrainian community for many historical reasons. That population associates public health efforts with a rather repressive government, and therefore they don't have a lot of vaccine confidence in that community, we have found. We have lots of experience with contact tracing. We have staff who are still in our department who participated in that investigation. And then, of course, many more of our staff got more experience during COVID. So we are actively preparing for what would we do if an unhoused person was living in a homeless shelter while infectious with one of the most easily transmissible diseases in the world. So we would obviously need to move and house that person, potentially with the caregiver if the patient was a minor, for 4 days after the onset of the rash. But any contacts who could not demonstrate full vaccination status or who refused post-exposure prophylaxis, which would either be another MMR shot or a shot of immunoglobulin, they would then need to be quarantined and monitored for symptoms of measles for 21 days. So this brings up flashbacks to the COVID hotel effort that I really don't want to relive, but just in case, we are preparing communications to our homeless shelter colleagues. We would need to communicate with potentially transportation companies, coordinate meal delivery services. Brendan probably got an email today from me through the system about having to dust off all those contracts and update them for measles. And all with the reality that our department does not have any spare funding to put towards this kind of effort. If this were to actually come to pass, I would be heading downtown to county administration looking for some funds to provide these protective services. So that brings up the fact that the current federal administration has cut $11 billion in public health funding to states, and it's only April. So we suffered our first DOGE-related casualty in my department. A COVID grant was funding efforts to support public health workforce through hiring and placing fellows paid for by New York State. They were placed in local health departments to work on a variety of projects that we all had to kind of submit and get approved. We had 4 fellows in our department working. 2 of them were working on climate health related projects. One was supporting our early intervention staff as they transitioned to a new New York State database that we're required to use for early intervention. Quite honestly, it wasn't entirely functional the day it went live, despite our team working with them for months, beta testing and giving lots of feedback about areas that didn't quite work or that were making the process take even longer. So that fellow and our 4th fellow was working with me to bring trauma-informed principles to all divisions and work processes. Across the state, 168 of these fellows and all the New York State staff supporting and running that program, they got an email about an hour after I did that their last day of employment will be May 30th. So I have neither the headcount nor the budget to offer any of them a full-time position. These 4 folks were doing really excellent work, so we are not going to be able to bring them on. The projects they were working on are going to go much slower than they did when we had a 40-hour-a-week staff member dedicated to them. I'm just particularly disappointed because we've just effectively taught 168 very bright, hardworking young people that some of them had masters of public health or administration, that public health is just not a safe field to work in. And so I'm afraid we're going to lose them to other areas of other fields. So that's just very disappointing and frustrating. The New York State Association of County Health Officials is working with the state, working with our elected officials to try to advocate for some clarity around what funding is or is not being impacted. There's a lot of anxiety in my department. It's gotten worse since the last time we met because we've had these 4 cuts for the fellows. We haven't lost any of our direct federal funding yet. And we haven't heard from the state that they're cutting any of our funding, but we know there's a lot of pass-through money that goes from the Fed to the state down to the local health departments. So not good times around here at the moment. And the final update I have for today is that we chose not to proceed with offering the deputy commissioner position to the one qualifying candidate we interviewed 2 weeks ago. They were not going to be a good fit. So that position is still open. And if you know any physicians licensed in New York State who have a master's of public health or who are board certified in preventive medicine and public health, please let them know that we would love to talk to them. And that's what I had to share today. I'm sorry it's not really much good news.
It is not. Somebody mentioned in a meeting this week that, last week, Head Start was cut. Is Head Start cut or we're on the watch? Anybody
Still
know?
on the watch, I think.
On the watch. Sad times for sure, and sadly, we are giving that message to the 168 fellows, but it's actually not safe in education or, anywhere
Right.
else,
Right.
fortunate.
I'm curious, the state shows us with MMR rates by age of 2, right, which is when that's supposed to happen, but I'm curious, do we have any information about like what the total rate is? Because I was just looking at it while you were talking, Dr. Mari, and I see that a lot of our zip codes are in like that 70 to 80% range by 2, but I presume that gets higher because folks finally get their kids in and get those MMRs in. Do we know like total population wise what those rates look like?
I can email Heather to find that out. I don't know it off the top of my head. I know we have a number of data sources.
I was just curious, like what how compliant we were as a whole population.
Excellent question. It's getting lower as the years go by with more and more folks choosing not to vaccinate or choosing to vaccinate with some alternative non-CDC schedule. But let me shoot off that email and see if I can get you an answer.
Thanks.
All right, well, thank you for the report, appreciate you zooming in. Is there something that you're watching as kind of most anticipated bad news, next steps kind of thing? Yeah, the next bad.
Next hit.
Next bad news. So we were given a public health, the FIG, public health infrastructure grant. This was a grant again through New York State that was supposed to again shore up public health departments after COVID, where we had mass exodus of staff, and any funding that had been made available was starting to get cut back. We've used that. It's really meant to be a workforce retention, recruitment efforts. And so we've used it for very basic things like fixing water fountains and getting folks, a double screen at their desk or things like that. I'm concerned about those dollars because they are in some ways tethered to the COVID effort and impacts to health departments after COVID. So that's a big chunk of change. I believe it was $4 million, $6 million over 5 years, and we haven't spent not even half of it because we're only in year 2 of the grant. And so I feel like that might be another target. It would be that could be pulled. If I have to lose something, I guess grants that aren't supporting salaries are better than losing headcount, but it's just not the message we want to send to our staff. There's already so much anxiety. I don't know how many of them might already be looking for alternate jobs. We're hearing rumors that things are being said, like at some of the town hall meetings with the unions, that their jobs are all in danger. And I haven't heard anything concrete. And I keep telling my staff that the second I hear something real, I will share it with them. But we get so little information from the state that leaves lots of room for rumor and speculation, and that just heightens anxiety all around. So.
And any follow-up from the meetings with the schools that you had before our last meeting? Hear anybody say, I can't wait, bring the user containers to Oh, no.
Oh, I wish that were the case. I did do a presentation to the county legislators in here in Monroe County, and many of them kind of heard my same spiel about concerns that some of the school districts were considering not participating. Some of them have volunteered to help liaise with the heads of school districts, so we're exploring that option. But no, I haven't heard anything concrete from any of them either that they're changing their mind about pulling out of the youth risk behavior survey.
That's great that the commissioners were in support.
Yeah, I mean, I'll take I'll take the support anywhere I can get it, quite frankly.
Yeah.
So,
All right, great. And did you want to introduce our Cure Violence?
our guest, yeah. So, Brent Decker is a consultant with Cure Violence Global. He and his team have been working with our department since September, I want to say, maybe earlier than that, thinking about how to assess the state of community violence in our county, and really trying to get the lay of the land about what is going on regarding community violence and where we might be able to contribute to combating that. So Brent, I will hand it over to you.
Well, thanks for having me. Would it be able so that I could share my screen just because I have a couple slides that might help facilitate the conversation?
Can you
That'd
give
be
it a
possible.
try? Go ahead and
Yeah,
try.
it's saying send request.
Okay.
Let me see. Cool, great, thank you. Okay, yeah, so like Dr. Mahdi said, we've been working locally for the past couple months on really doing something that we call kind of a readiness assessment. But before I get into it, my name is Brent Decker, Chief Program Officer at Cure Violence Global. I've been with the organization for about 22 years. We started really from a physician who came from the World Health Organization, Dr. Gary Slutkin, who kind of came back to the US in the mid to late 90s and really thought about kind of the public health response to violence and violence prevention. And so, as many of you are probably aware, back dating to the 70s, it was something that was kind of like declared a public health issue. And so, what we did at Cure Violence Global is really take the more kind of epidemic control portion of public health and apply it to community-based violence. And as a lot of the studies have shown in the past couple decades, I mean, that violence really behaves like a contagious disease, like an epidemic. And if we treat it as such, I don't know why this thing's advancing, I apologize. If we treat it as such, we can get results at a community level. And so just kind of going through this, I mean, oftentimes I'm not presenting to a board of health, so it's sometimes I spend a little bit more time on this, but, really thinking about the contagious nature of violence. I mean, that there's clustering, that there's epidemic waves, there's population characteristics, and there's a means of transmission. And, for us, this is obviously very important in understanding what to do about it. And so when we talk about violence clustering, we can see cases of cholera here next to cases of violence in my beautiful city of Chicago. We can see we has a clustering effect. It spreads like a disease. It follows very similar epidemic waves. And for us, I think the most important thing in understanding of kind of how the public health sector can be activated to be involved in violence prevention is how it's transmitted. And, and it's not that these are bad people that need to be punished and kind of the tough on crime perspective that's often pervasive in local policy. And so, really understanding how violence is transmitted through observation, through witnessing, through experiencing trauma. And then this, unfortunately, there's a lot of methods of exposure to violence, right? And so we have community, the media, at home, at school, sometimes state-sanctioned violence. All of these things can then influence folks, once they've been exposed. That leads to kind of further events that take place, and what we see in areas where violence is acute, kind of this cycle of multiple exposures leading to multiple events that lead to multiple exposures that leads to multiple events, and we get kind of where we are. And again, I'm going fast because this is, Board of Health. Of course, Cure Violence Global, understanding it within the context of social determinants of health, and so issues of like historical racism, colonialism, all of those things obviously is the context for all of public health. But what our approach is really trying to deal with is kind of more on the epidemic control, deal with, shootings, killings today, tomorrow, next week, next month, as part of a kind of broader strategy to address the social determinants of health. The good news, as you all know in this room, is we know how to stop epidemics. And, it's three things: interrupt transmission, prevent future spread, and change group norms. And so these are the things we've taken and kind of applied to community-based violence. Although we've worked in other forms of violence, but this is the major stuff we've worked in. And so in terms of interrupting the transmission, the way that our approach does this is we have workers that are called violence interrupters. And these are folks that come from the neighborhood, have ties to the individuals and groups that are most associated with violence, right? So these are folks that have many times been to prison, been involved in either the crews, cliques, gangs, militias, whatever the groups are locally. And what they do is they're able to use their credibility, their understanding of kind of what's going on to engage folks that are likely to be involved in violence. They kind of keep their ear to the street. And as conflicts erupt before violence takes place, they're able to step in using their credibility and through training through us and kind of mediate these situations, right? To stop some of the back and forth of violent events. And that's how we're interrupting some of those things. The second part of the approach has something called an outreach worker, which again, for Department of Health, this is very basic public health technology, but these are folks, again, from the community, have the relationships, and their job is really working long-term with folks to help them make healthier decisions around the need to use violence to settle disputes. On top of that, has to do with wraparound services, back to school, employment, things of that nature. But really the focus of the intervention is trying to help folks make healthier decisions when it comes to the need or the perceived need to responding to my conflicts or slights or things online with violence, right? And so that's really the focus of it. And then the third part of the approach really has to do with like community norm change and thinking about how do we shift some of the peer expectations that young people have. They're not all young, but a lot of young people that are involved in violence, of what it means to like either be a man or whatever these constructs are that lead me to thinking that I need to resolve this issue with violence. And so we do this through public education campaigns, community events, things of this nature, but really trying to interject different and healthier behaviors using credible messengers at a kind of community level to shift some of the norms around the acceptability of using violence. And so that's, been the Cure Violence approach. We've been doing it for about 25 years. There's been numerous independent evaluations that are all on our website. Ones that have been released in the city of New York. I don't know if you saw this. The comptroller just released something like 3 weeks ago or something, looking at basically 10 years of implementation and really talking about significant, like 20% reductions in shootings and killings in all the areas that we were working in. And so that's all available online as well. So there's been just tons of evaluations in the US. We also have programming in Latin America, Caribbean, and Africa. There's been evaluations on that as well, which is all on our website. And so that's what kind of brought us here. The health department or Department of Health reached out to us to think about how could this approach be useful or helpful locally. And so as we do this with any jurisdiction, any city or health department or country, we look at trying to answer about 7 questions, right? Is there local governmental agency like with the capacity to implement the model? Do things like official data exist that we could access to be able to figure out hotspots, determine age ranges, demographic information of those who might be at highest risk? The data exists that we can monitor the program and implementation. Do community organizations exist that could really implement this approach? Because this approach is, although there's oversight by health departments or mayor's office of criminal justice, it's really implemented on the ground by existing community-based partners. So are those folks, do they exist? Are they interested in doing this type of work? Are individuals exist that can serve as interrupters and outreach workers, and then kind of given those series of conversations, thinking what some recommendations might be in terms of applying this approach locally in the jurisdiction. One thing that was a little bit different of the local context in Monroe County and Rochester specifically is that there's already a lot of groups and local government agencies that were doing our approach. They either received training from us like a long time ago, or the SNUG program in New York that's based on our approach. And so as we kind of got to understand the kind of local landscape, we really wanted to change the trajectory of the assessment to really think about what's going on locally that's kind of evidence-based or evidence-informed. What additional support could we potentially provide through the health department to those groups, and see where were we in the position to do so or not. And so that's kind of where we shifted the focus. So it wasn't starting a new program or wasn't starting a new approach locally, but it's kind of thinking through, given everything that's going on, how could we share some of our evidence-based practices locally to help with the overall objective. And so when we think about like the capacity and stuff, like I mentioned, there's just extremely high levels of capacity locally. You can see on the slide here, and I think we can send this presentation around, and I believe Dr. Muddy, right, we're sending the report to everybody so folks can kind of read through it. But there's just a lot of things out of the City of Rochester's Office of Violence Prevention, Pathways to Peace, Office of Neighborhood Safety, Rochester Peace Collective, and there's just a lot of groups doing the work. The state of New York already applies the SNUG program, which is based on our approach there locally. There's a lot of violence prevention coordination and planning efforts in the county. As you can see right here, and then of course, then the Monroe County Department of Health with obviously high levels of capacity. In terms of the data through the Rochester Police Department's open data portal is there. And what we're really just trying to test is like, look, can we do cluster analysis of it? And so for Rochester, the answer was yes, that existed. We would still have to coordinate if this work were to be in more parts of the county in terms of having other data sets. So those is all included in the report. Just two examples of it. We're looking at hotspots and then doing some police beat analysis. Like we mentioned before, there's many organizations that already do something very similar to this. And so I think that's really good and exciting in terms of local violence prevention efforts. And we met a lot of folks that already kind of serve as interrupters and outreach workers. So this is different than other readiness assessments that we've done. Like I said, which changed the trajectory a bit, but I think we were able to, in meeting with those groups, really kind of identify how the health department and how Cure Violence Global could be helpful to the local efforts. And so we landed on being able to provide evidence-based training to the existing community-based organization and their workers. And so oftentimes folks receive money to do kind of community outreach or violence interruption, and there isn't the same kind of level or attention paid to training and support. And so what we wanted to do is then, based on our evidence-based programs, provide a program manager training. This is for organizations that implement these type of approaches. And just it goes through, it's like a week-long training just on how best practices to kind of manage the intervention. We wanted to provide actual training for interrupters and outreach workers. Some of them receive trainings from the SNUG, some receive trainings kind of from different agencies, but we thought it would be good just to offer to everyone the same training, really based on the evidence on the approach. And then we proposed doing some post-training site visits to really go and spend some time with folks that are doing the approach or the approach something similar, to be able to provide additional support and additional kind of recommendations on management or interruption techniques, et cetera. And then a series of booster trainings once we've done these trainings, just to, again, support kind of the long-term community violence prevention infrastructure locally. And then we want to develop kind of a local training center in terms of sustainability out of the Department of Health that we would kind of work to develop so that it could be sustainable long-term. That one of the roles of the health department would be being able to provide these trainings long-term. to existing organizations, to new staff that come on, et cetera. And then we also provided just information on if there was a requirement or need to increase coverage or do specific cure violence programming, that at least we had it on the record. And if folks decided they wanted to do that, that would be there as well. And so this is just a very quick summary of the findings. And, you know, for us, you know, we really view violence as a public health issue, and we think about it in terms of systems. And so I think where we landed on with the Department of Health of its role, like providing support and training to existing partners that are doing stuff, that kind of really fits in with both our approach, but also how things have been going nationally until very recently, in terms of this being kind of an adopted, you know, way of addressing stuff. That was just my very brief overview of kind of our approach, some of what our findings were, and kind of where we landed. So I could stop right there. I don't know, Dr. Amati, if there's something you wanted to add to that, or if I missed anything.
No, I think I would just add that, you know, Cure Violence Global and Brent were very clear that they think we probably could do with a couple more actual interrupters in the community for the size of the city of Rochester and the frequency of violent incidents. However, we really got a strong sense from the partners that we're trying to build relationships with that was not something that was readily acceptable as an option at this point. So we are trying to honor the expertise, the knowledge, and the preferences of the folks that have been doing this work for a number of years. And so we are trying to build trust and build those relationships by providing these trainings, and potentially in the future hope that that suggestion will be better received than it currently is.
Well, thank you. That's really great. Thanks for the report. I guess I've thought about violence in that way before, but it was great the way you presented it as epidemic and exposures, and it makes a lot of sense. I have questions, but questions from you all? Yeah. Go ahead, Sarah, and then, okay, that's
But
great.
Brent, this is just a clarification, or if you could just let me know. On one of your slides, you said there was 3 points. One was healthier decision and responding to conflict, and the other one was change community norms. I didn't hear the first one.
Interrupted transmission,
Sorry,
prevent future spread, and then change group and community norms.
say the first one again.
Interrupt.
Interrupt transmission, yeah.
Transmission, thank you.
Yeah, right. And that's where the role of the interrupter really comes in, of like trying to get in between some of the conflicts, either before they lead to violence or prevent retaliation once violence has occurred.
Perfect, thank you.
Yeah.
How many interrupters are in our community?
I think there's somewhere around 40, right, Dr. Mai? It's in the report. We did
Yeah, let me look it up. I've got the report open here. 1 second.
yeah. So it wasn't insignificant at all, and I think there's been a lot of good work done. When we think about kind of
53.
like 53 altogether. Yeah.
It's official though. I think they're interrupters.
I just had a question. So did you circle back to the groups that you met with, and what kind of response did you get based on the recommendations that you shared?
Yes, we have been in conversations with many of them. They seem fine with waiting for us to be able to actually get the RFPs out to find the folks who will provide the trainings. There just hasn't been a lot of appetite for more staff boots on the ground. I suspect there may be a concern that, there's an attempt to take over some of the work, which is obviously never our intention. And there's certainly enough work to warrant, I think, a couple more interrupters. But it's been slow going to just build those relationships and earn trust. Some groups were developed out of people's lived experiences of losing a loved one to community violence. And so they're very passionate, and folks are doing a lot of hard work. And so I think it can feel a little bit like, oh, Monroe County is coming in and trying to take over, or, you know, and we're trying to just be respectful and build those relationships.
So so your next step is to send out an RFP to find someone to do the technical assistance?
I'm sorry?
The next step that you're thinking is to do an RFP to find someone to do the technical assistance?
No, we're going to put out an RFP for the folks to do the training, to provide the training. Cure Violence is certainly a well-known entity, but we are the county, and we need to offer the opportunity for anyone who could provide that training to get a chance to submit an application. And there will be another RFP coming out as well that is much less detailed and will call for ideas that community members and other agencies might have for how to prevent or interrupt violence as well. Both of those are so close to being released. I'm not able to say anything beyond that. And there's been a number of delays already. So please don't ask me anything more detailed about them.
So for me, it's very frustrating because as a person who's not steeped in this work, your report says, yep, you've got this, you've got this, you've got this, looks good, but we know the violence problem just keeps escalating. If I'm being naive in that, please let me know. So what is the thing? Is it more training, you think?
Yeah, I mean, I think it's right. So, I mean, oftentimes when we're engaging in jurisdictions, like the yes is like, is this possible, right? So there's been some jurisdictions we work with, or some, in other countries, or even in the US, where it's like, there's not buy-in from a government, you know what I mean, to do oversight. So it's like, no, we can't, so it's like a non-starter. Two, there's not data. So it's very, I mean, when we were in Southern Iraq, you should have seen me. I had this like pizza box up, we're drawing a map, there's, because there just was no data available. The third thing having to do with like community organizations or interrupters, like if those kind of relationships don't exist, it's a non-starter. And so what we think would be, so given all those criteria, they're there, the next step is then really getting the evidence-based practices to be kind of uniformly implemented across the various spaces. And as Dr. Amati is saying, it's like that can be complicated, and there's a lot of folks doing a lot of really good work. And so as we were kind of changing a little bit the direction of the readiness assessment, respecting the existing infrastructure, the idea is like, why don't we provide more training and support so that some of the more kind of evidence-based practices can be implemented as part of the way that the existing groups are doing business. And so I think that would be a great step forward in terms of building on folks' natural capacity, but sometimes there's issues around management, what hours to work, how do we provide supervision, what is the follow-up on the there's a lot of detailed kind of stuff that organizations have found to be very, very helpful. And the ones that have done these things are the ones that like have been evaluated and have been shown that they can, really reduce violence on a community level, not just on individual outcomes. And so that's, I think, one of the things that the partners even brought up to us was this issue of additional training, additional support, things of that nature to kind of amplify what they're already doing or provide some more structure. And this is like a typical thing that there's a lot of, grassroots organizations or faith-based organizations that like are working with what they have, and they haven't always had access to, evidence-based trainings or the resources to do so. And so oftentimes the places that do the best have been doing something similar, and we're able to work with them to build out their toolkit a little bit and to build out some of the kind of strategic planning from a public health perspective, and they find it to be very helpful, and it fits in very naturally what they're doing. So I would say kind of some additional support training, and then really documenting the work. So I hope that clarifies your question a little bit about.
Yeah, it does. A lot of well-intended people, but if we need to be doing the right things with those intentions, for sure.
Well, and the question you raise, Teresa, there is an impression that violent incidents are getting more numerous or worse, and we have been engaging the partners and trying to engage in conversations around, is it possible to start to pool and coalesce some of the information from these various groups to really get a handle on what is the actual narrative, because there can be the perception that violence is getting worse. The Rochester Police Department, with their open portal, we can look at numbers of incidents, and sometimes even if those go down, does that mean that the severity of those incidents is getting worse? We can all think of some of the kind of mass shootings recently that have made it feel like, yes, absolutely, it's getting worse. But we're also trying to engage folks and think about how do we share information and maybe pull together from each of these various groups a narrative to really explain to the community, is it getting worse? Is it getting better? Where? And that's going to take a lot more conversation. Because we are new to this area, new to some of these partners, and we're still trying to get folks to trust us and talk to us and be willing to share something like that. Where can we maybe host a community dashboard about violence, or some folks have some experience with storyboarding about, you can dissect one major incident a little deeper to go beyond just the absolute numbers. So that's the work that we're working on.
Yeah, thanks.
Sorry, Celia, go ahead.
Thank you. I have quite a few questions, but you're probably not there yet. But I'm just wondering, out of these 53 interrupters, people have youth interrupters or no, or they wouldn't qualify?
When you say youth interrupters, you mean like people younger than 18?
Yeah, like are they, is there any need for them? Is there any discussion about youth? Like
teen empowerment, do they do that?
What was the last thing you said? I'm sorry.
Sorry, there's a local organization called Teen Empowerment. They have a lot of advocates. Are they a participant?
Yeah, I don't know that we met with them specifically, but typically a lot of the organizations that we met with, the target population, quote unquote, is really the age range, usually like 14 to 35-ish is typically, with a peak 16 to 26, more or less. But the issue, even beyond age, which is an important one, is credibility. And so I think it's important that the workers have credibility with young people who are likely to be involved in violence. And so what we see in a good team is it's a mix of age, it's a mix of experience, that are really, if it's all like old people like me, do you know what I mean? Like I'm out of step. I'm not, you know what I mean? I'm not cool. I've been cool in a long time. And so it's like having young folks as part of the team that really understand the dynamics and can really reach out folks is an important characteristic of it. We didn't meet all of the teams there, but I know some of the SNUG folks. I know some of the stuff out of Office of Violence Prevention, out of Mayor's office. They have some staff that are a bit younger, but it's, that's part of like the strategic thinking about these things, of ensuring that we have staff who are engaging folks that like have the credibility and even understand what's going on with younger folks, because it's different. Every generation is a little bit differently. So I can't speak to all the programming. I think there's some of that going on, but it's an important point.
I would guess that the 4 different programs that we actually did meet with, it was Pathways to Peace, SNUG, Advanced Peace, and Rise Up Rochester. My understanding is that they employ all, at least 18 and older.
Yeah, sure. Right.
Very specific question.
And the only other question, I guess, is coming to my mind is around the clustering. I don't know if this is going to be in the report, but I'm thinking about specific things around homelessness, mental illness, drug use, and youth as well. And just if those are the elements that are increasing, where you're seeing the higher pockets of violence. So I don't know, is that information going to be drilled down so we can look at that data, or is that already done and I'm not up to speed with that information?
So we primarily looked at aggravated assaults like shootings and homicides to figure out the kind of clustering of violence. But oftentimes, if you were to take any map of the social determinants of health and do the same analysis, It's always right on top of each other. So we can kind of safely. So part of the job of the community-based partner, if they're working in this specific area, and part of the training is really being connected with all of those services and all of those things, so that like when there's overlap, or there's trends that might be based on some of those things. I mean, especially around drug trade stuff, to be honest, like that's, this is the type of like connection that's important. But for us, the main thing that we're looking at least from our vantage point, are actual shootings and killings. And that's kind of like how we from there kind of engage and understand the other stuff. But you look at almost any social determinant of health thing, it's the same map, unfortunately. Not always, but a lot of the time.
So no, the report that we're gonna send you all doesn't include that level of detail. It was really focused on the actual violent incidents. But we are very much aware of the overlap of all of those drivers. And we've got really good data from Common Ground Health and from other folks around the areas that have those highest levels of need.
To Dr. McIntyre's point earlier regarding, interrupters, I'm just curious, from previous, states that implemented this, did they actually incorporate youth as interrupters as well? I know that Senator Brooke has a youth mental health group that's going around. Commissioner Isaiah, is trying to get a group going, a youth group going around mental health. Sometimes it's different when a peer-to-peer has those conversations of healthy choices and decision conflict resolutions as opposed to an adult. So I'm just curious, a part of this report, or is that something that was incorporated in other states?
Yeah, so typically most of the folks that serve as interrupters and outreach workers are full-time employees of the agencies, so they're usually no younger than 18. So it's usually 18 and above, for like labor laws and things of that nature. What we like to see, like I said, is to have some interrupters that are closer to the younger spectrum of it, right? And some that are in the middle spectrum, and some that are a little older, just in terms of when we think about like the issue of violence and those who are actively involved in violence, like having to be able to engage the local like clique, crew, gang culture stuff, what I mean, is important. And so you need to have kind of multiple lenses and multiple sets of relationships and credibilities to be able to do that. But they're all full-time employees. Think of them as like community health workers. I would totally agree that peer-to-peer stuff is very important. I think the cure violence approach we always say is like, we are not the solution. We have a very specific lane. It really has to do with like epidemic control about shootings and killings. And so all of our things are designed kind of in that lane, but it's never to be understood, or if I say it's not like in lieu of anything. I mean, it's really, as you saw that map I kind of put up, spoke about briefly, it's like this is one piece of it, and all those things that we would never say like to a jurisdiction like that's not important or don't do that. I mean, this is just one specific thing that's able to help with reducing shootings and killings in the short, immediate, and somewhat long term.
I think this clearly speaks to what we were talking about last year with our violence guy from our IT, who I never remember his name. Thank you. Yes, who was saying that the age of people committing violence is older. And we always want to focus on the youth. And certainly that's the drivers, and certainly there's room and a need for young people to have self-value and move in that a different direction. But if we're talking about interrupting violence that's already happening, it seems like we would need older people, just from what he taught me. Again, it's not my field, but so I think, in health, we're always thinking about, changing the trajectory early. But he was saying, it's really older folks that need to be interrupted and change gear. So I think we need both. So it's interesting that you're presenting something that can be done for an older than 18 group.
Yeah,
And the other thing too, I'm sorry, go ahead, I'm sorry.
I was gonna say, no, I don't disagree. With that, I haven't always been the Office of Mental Health Director, and you have a little bit of a story. Being in the community where violence, was occurring, grew up in the ourselves in Denver area. Again, that was a long time ago, but I do know of kids being the drug runner and kids, you know what I'm saying, having a lot of gang affiliation, with older people. And so I agree that we always have kind of that thought process, the younger ones, you gotta help save them. But also there is a reality of street interactions with the OGs and the younger folks. We had somebody in the community, I won't say a name, who wound up shooting, an officer, you probably would know who it is now that I said that. And it was communicated within the community, the street folks, that there was an older person who really did it and told this person to take the charge. So again, it was that older population that was influencing the young. So that was only the reason for my emphasis of the youth, but.
Yeah, and clearly there's a problem among the youth too. I mean, I
A lot of times.
18-year-olds talking to a 14 can be very powerful.
Yeah, for sure, yeah.
I was gonna say that a lot of, unfortunately, a lot of the younger people get caught holding the weapons too.
Yeah, there you go.
And part of it is so that they don't catch a charge, they're holding for someone else. So I am curious though too, like in hearing the request for the county to not like staff up and replace existing resources.
Yeah.
I get that and I appreciate that. I do appreciate the idea that we would have conversations around fidelity and trying to come up with models that work across different sectors of the community. But I do want to understand, and I know this isn't fully formed yet, the RFPs that might go out yet, but will there be opportunities for grassroots organizations similar to the Peace Collective that the city has been doing to apply? Is that what I heard? Is that how we're framing it?
Yeah, one RFP will be very specific for a group to provide the trainings to empower and equip the groups that are already doing the violence interruption, and one is written very, very broadly to really consider any strategy that folks want to put forward.
And one of the challenges, so I've seen so many different iterations of what we do in city government, right? With Pathways to Peace, for example. Models where it's full-time staff or it's part-time staff to kind of get some flexibility. And I think as part of the whole training process, it would be helpful to understand those best practices, what other cities have done it well. Because I think we implement a lot of models and I agree, the city's committed. I mean, the city is interested and wants to do this work and do it well. But it feels like the goalpost changes pretty often. After a couple of years, we go on to the next best version of the same thing. And so it'd be helpful to understand where can we be more consistent as we start training city employees. And I appreciate that offering of support from the county to the city to help us think through some of that.
Yeah, and I don't know if that question was directed to me. I know that Dr. Myers, but I mean, I think you're right. They're in the violence prevention world. There has been a lot of shifting and changing of names and things of that nature, but I think the thing in public health and the thing with it, these are like consistent ideas and consistent strategies that can apply themselves in various contexts. And so I think really sharing best practices of fundamentals that doesn't change. You can call it whatever you want to call it. Do you know what I mean? Or it can be framed however to frame it, but there are kind of specific things that we know in public health of like how to stop epidemics. And so I think if we can like get that be part of how we're doing business, then it can ebb and flow a little bit in terms of names and new administrations. But I think if we do those things, it can be linked to community level outcomes, And so I think part of the idea around the training that kind of came up with the partners, and they mentioned that as well. I mean, I think a lot of folks share that frustration. It's like we were snug for a while, we did ceasefire for a while, you know what I mean? And it's just like And in that, as things change, there hasn't been the same type of support and training underneath it. Do you know what I mean? And so I think if we can establish that, especially long term with with the Department of Health, it's a rooted thing that's going to continue to provide this training. I think it's better suited to actually have the type of impact that we all wanted to have, at the community level. But I think that's a great point.
So, so this is just sort of, you said aggravated assaults and homicides, so where does like domestic violence and youth being exposed to violence in that way come into this model?
So, one of the booster trainings is kind of thinks about gender-based violence or domestic violence, but that's not necessarily our lane per se. Do you know what I mean? In terms of like a certain percentage of the conflicts we get involved in, well, some would argue all violence is gender-based violence, but in terms of domestic violence, right, that like there's a certain part of that kind of overlaps a little bit with what our staff are capable of doing. In the booster training, we kind of talk about some of those things, but this is where the partnership's really important, because I think our expertise is not in kind of domestic violence, right? It's more on like community-based violence, more public violence, although there's some overlap. And in the management training, especially with folks, is like making sure that workers understands some of their limitations, you know what I mean? And then, but more importantly, what are the resources locally that if this is something that they get engaged with, or is like a secondary reason behind something, you know what I mean? That they know where to make the appropriate local referrals for stuff. And so that's for the kind of domestic violence, gender-based violence stuff. And then I'm sorry, what was the second one that you said?
No, that was it, yeah. That was my
Okay,
question.
right on.
We recognize those are two different, moderately different sources of the conflict. And so we don't anticipate that we would use this cure violence model if working exclusively on the domestic violence model was our target. And so working on the community violence area first is where we thought we could have the biggest impact. We recognize domestic violence is a problem. It's huge. I don't currently have any expertise in that area in my department, and most of the expertise that we have around the community violence, we're learning and gaining from working with Cure Violence Global. So.
Well, I'm excited that the health department is taking the lead, and I'm just excited that they're bringing folks together, do it in a consistent way. So that's all great. And I certainly have a lot to learn. So thank you, the experts in the room. And
I would actually say that the city has been pulling together a bunch of these workers for a long time. Councilman Willie Lightfoot has really been pulling together the Rock Against Gun Violence Coalition for years, and we started attending his meetings. So I would not say that we are the leaders by any means, but I think we can be really valuable partners, for sure.
yeah, absolutely. In the most respectful way that I said that is what I meant. I mean, I'm glad we're taking a role, whatever that role is.
And sorry,
Yeah, go ahead.
I mean, we talk a lot about evidence-based practice, but a lot of the stuff that I'm hearing also, we haven't really had anyone really looked at what we're already doing. And I guess the difference is that maybe some of the things that we're doing in Rochester maybe haven't been written up and published. And, I don't know, because I'm sure there's best practices that from that, because if you're saying that all of these boxes are checked on your readiness assessment, then there has to be some kind of evidence or data or something that's working in our community. At least even just curating relationships, I think is
Sure.
one part of evidence that's pretty much worked here. So
and there is a lot of work that, for example, Dr. Rashad Altheimer has done at RIT. I mean, he came in and spoke to the board I don't even know how long ago. He's been partnering with the city for a long time. Miguel, I don't know how long, but he's been their research partner. And so a lot of their work has been posted on what is his department called? It's the
Center for Public Safety. initiatives.
Thank you, Center for Public Safety Initiatives. And so,
It has to be published in the literature to be evidence for a lot of things, and that's probably where the issue is.
Sure. And so we have been talking with his team and certainly reading up on a lot of even the publications and just the reports that he's put up, even if they're not, double blind, randomized controlled trials. There is a lot of learning and there's been a lot of effort put in place already. So we are basing a lot of our work off of a lot of the work that has already been done, because there's decades of effort here documented in many of those reports.
Thank you.
Yeah.
I think some of the grassroots organizations, they just don't have that support level to be able to get the research to show how.
I'll say that. Yep. Mhm.
And unfortunately.
And it becomes a disservice to them because then,
Yeah, there you go.
you know,
Exactly, which is why the new term is like that practice base. Instead of evidence base, but you're absolutely right.
Yeah, I've heard evidence informed, practice based, is that, yeah.
And I'll say
maybe-
you're,
Go ahead.
I'm sorry. No, I'll say you're exactly right. I mean, a lot of the groups do a lot of good work. There has not been the resource or they haven't been centered to be able to write this stuff. Oftentimes, even the previous administration, when they were talking about it being evidence-based, they were using kind of like the research on us and applying it generally. Do you know what I mean? Because not everyone has had the type of research that we've had, and sometimes people give us more money to, not us, they'd give the researcher more money to do the research than the actual programming. And so it's not the obviously that there's a lot of problems with that, but I think what is happening locally, they have been writing reports. There is a lot of good information about what's going on, and I think they've based a lot of what they've done. Advanced Peace is one of the parts. They have evaluations associated with their stuff. Snugs stuff's kind of based on some of our evaluations that happened in New York. But yeah, I think having more resources available to really document and demonstrate the effectiveness stuff that's local is like, we're all on board with that. And we think we would never say that that's like, it's an important piece of it for sure. And part of the readiness assessment is like looking at the data, and this is again probably too much in the weeds, the police data, but like understanding it, what is the community saying about it? Because the definitions are different, the reasoning behind it, like what does it mean? These are all different concepts than like how it's understood and from a law enforcement lens. But at least in our perspective is understanding where those clusters are to then work with the community-based partners to think about, okay, given that, what does this mean? Who's really involved? What are the real underlying things? And how do we engage that using kind of public health approaches, if you will?
perspectives. Yeah.
Yeah, for sure. And hope.
I just want to ask a quick
Yeah.
question. This is my first meeting, and then I'm from the Council of Agency Execs. Would the RFPs possibly provide an opportunity for some of these organizations to partner together to apply to the RFP? Is that an option so they're not just one person, but maybe a grassroots organization and somebody else, or is it just a RFP for one entity?
The RFP is written really broadly, and we've not decided that we're only going to accept one application. So if folks wanted to get together and apply together, I don't see a reason not to.
I just wanted to add something to the whole evidence base too, is always keep in mind, is it just within the behavioral health, that's my area, but keep in mind that some of these evidence-based, the participants do not look like the community. And so, however way going forward, just ensuring that it does.
That term evidence-based is fraught with problems. It's a good idea. We want stuff that works, right? But works for who, works when, works.
And
how much
research is
evidence do we
important,
need?
research
Of
is
course,
important,
yeah.
getting it published and, it's definitely a place for that, so. But this is really good.
I will say that violent crime in the city is down.
Yes,
Is
it
it?
is now.
Thank you,
It is
yeah.
I was gonna say, it's not, I know.
Shootings are down,
It's one of those-
homicides are down.
Okay, just said it, you should have said it, we're going into spring.
I know.
Yeah.
I know.
So not cold.
As of last year.
Thank you, Sarah.
So I will say, but yes, we are going into the
I mean,
spring.
it would be really cool to evaluate even those 4 programs and outcomes, and then what if you're in more than one, or what if we implement all 4 at a time, is that solve the, I mean, you know, cause I do think we are doing some good stuff, but is it working? I don't know, I mean,
And Sarah, do we have an evaluation for, I know we have for Advanced
RPC,
Peace, Rochester Peace
Yeah.
Collective,
those two.
but nothing for Pathways.
Nothing for
Because it's
Pathways,
been
I think in a
ongoing
long
for so long.
time.
Yeah.
I think that was one a long time ago. I can't really speak to it.
You try again.
You know what's gonna be interesting, and I'm just thinking out loud, so take it for what it is, but what would be interesting is to see the effects of this federal cuts and see how it actually increases the violence.
Yeah.
Unfortunately, you know, we're looking at how it may, you know, we're questioning how is it gonna increase suicides and increase, you know, mental health and substance usage, but how does it also get violence? If I can't feed my family, you better believe I may, you know, think about other ways to be able to feed my family, so.
we're already seeing that. Shooting it.
Sarah, where are we finding that data?
So the Rochester Peace Collective, evaluation is ongoing. The, Advanced Peace, there was a report September-ish, I wanna say, don't call me on that, but sometime last year. I don't know if that's public, but I can find out and maybe send it to the group. Those are the only 2 that I know about. I think, again, I think that we've done Pathways before. I can't tell you where that is necessarily, and then the rest of the organizations, I'm not sure, because I'm not from that city organizations.
But that database that shows violence, you know, every minute or whatever it is, you can't trend that, or is that trended?
The open data portal,
Yes.
that's what I'm saying.
Oh, is that what
According
they
to
use?
the open data portal,
Yeah,
like violence in this term that we're talking about is down.
okay,
That's what I'm
great.
saying, but
Yeah.
that's directly.
Yeah,
So the open data portal is like the police is putting in information into that portal
Yeah.
and then we're pulling it, you know, back
Yeah.
out, but the reports, I can look
and
into
then
the
in
advanced
addition
piece
to that.
one.
Okay.
Yeah,
And the city's Office of Violence Prevention, they have a bunch of resources available on their website.
Any that I can review and write up?
Yeah, we'll publish
Publish,
it. One way to go, one way.
Well, one final thought, I know, Dr. Marty, you're probably not looking for more work, but just from this conversation, what I'm also hearing is there might be a gap in providing like some backbone support or evaluation component support for smaller grassroots entities to
Yeah.
think about like what documentation do they need
Yeah.
or could they use? And maybe that's part of the training and just kind of getting people up to speed on how do you actually tell
Right.
your story for this work.
Right. And so when we were imagining how this would go down before talking to folks, we were thinking, you know, how do we empower organizations to really demonstrate their effectiveness? Because when, this was even before Mike left, when Mike started this effort, man, it's got to be in 2023 now. I don't know. We've been talking about this a long time. But he went out and he wanted to get to meet the folks that are doing the anti-violence work and really struggled to get a clear picture of what exactly were the data that people were collecting. Was it different from one to the other? Were people, how were folks demonstrating effectiveness? And I don't know if it was just some of that natural hesitation when a new partner is coming around, but he found it quite difficult to elicit from a number of different groups exactly how are they documenting that they're having an impact, because there's a lot of hard work that's going on. There's a lot of support that's being offered to victims of violence and the communities when these events go down. But we didn't, it was not easy to find data around efficacy that was being readily shared. So that is something that we would love to be able to help address.
And that's why community needs to be researchers.
And we need to empower the community health worker to also be a researcher. You know, I think that title, it alludes people who do have primary knowledge. And that's the way you get into the community. It's not me trying to get into the community or somebody who's not, it's somebody who's of the community. And I think it's hard to power, but we have to. You know, I think about, trying to work with the university. Yeah, they got an administrative rate of about 50%. I mean, that's.
Point to me,
I'm just saying, it makes it very difficult for our community to partner with researchers to do this. But Dr. Altheimer is a great partner. I know Jordan, we're once again trying to work together to do something around, victims of violent crimes and their surrogates. So, we're committed to try to get the serve thing off the ground again in a different way that we're imagining. But just keeping that in mind about the research work and we can empower to really get that information.
And I think, and to that point, I think it's important if you're gonna use community, yes, but not only that, but recognition. And so if things are published, you should be one of the authors, associated with that. That goes actually a long way.
It does.
And so that's important.
We have rules at Jordan. If you come to do research with us, these are the things you need to follow. And actually, when I was at Common Ground, we did that with the coalitions. Don't come without thinking that our names aren't going to get on your paper. If we're not aligning your budget, then obviously we're not that important to what you're trying to do.
And another point too is if the RFPs are going to, and I'm sure Dr. Madi is thinking about this, but she thinks this way as well, is that if RFPs are going to be combined, ensuring that bigger organization is not contracting high with these smaller organizations, so their percentage is so high that it's breaking these grassroots organizations.
That's that admin rate I'm talking about. It just kind of gobbles up everything.
Yep.
But a lot of times
when we
the
do
bigger
it to
right, go ahead.
I was gonna say, like, our administrative rate up until this year was 10%.
Yeah.
And I go in with the U of R and there's a 50%. It's,
For partnering.
Right.
But aren't there local organizations? Aren't there cheaper local organizations?
There are, yeah,
Yeah.
there are.
For research. You can partner with.
Well, I mean, there's organizations that can provide backbone staff to these grassroots organizations.
Well, maybe that's a consideration.
Yeah, the only thing is that the University of Rochester is a research, you know what I'm saying? And they have the clout and they have the IRB. There you go. The IRB, exactly.
They have a lot of depth too.
They do have a lot of depth, yes. So you're gonna want, if I'm a not-for-profit, I'm like, listen, I wanna go with the U of R.
Well, I'm trying to, we're trying to RIT. I partner with anybody. What's a women?
We have to talk about the nominations committee before we fold, so I just wanna wrap it up. Great conversation. Any last minute has to get out of your brain comments?
Sorry, Karen.
Brad, thank you so much for your work with our community and that report. It was really great and wonderful to hear your comments and your answers to our questions. So thank you.
Yeah, thanks for having me.
I'm really grateful to work with you guys, Brent.
Yeah, it's been great.
So we'll look forward to continued relationships. Hopefully.
All right, great. I'll leave so you can have the rest of your meeting. All right, bye-bye.
Thanks, Brent.
Thank you.
Mari, did you have any other points for the commissioner report?
No, that was it.
Great, thank you very much. And a very brief president's report is yielding the floor to the nominations committee. So thank you so much, Ms.
Yeah, so the nominations committee, Aaron and I met. So we just have a couple of things for you all. So first of all, Aaron very thankfully put together some language that we're thinking about posting on the website, and then also maybe putting it through a press release. So I think we just wanted to get like the A-OK from the group. This language was good to go for both the website and some sort of press release. I think it's gonna help us with.
Yes. And this is for the at-large member that will be needing to be elected for September, but also we kind of have a ad hoc process. We definitely have a diligent process and we certainly have a lot of thought going into it, but this kind of solidifies our getting nominations part of the process.
Yeah, so the idea is that this would be, I mean, the paragraph will be on the site, hopefully forever. So we can have a running list of people who might be interested. The date was just to get them by the May meeting. Or the May meeting here. Yeah, for them to become start in September.
So quick question. So but they can be a nurse, right?
Yes.
Okay.
They just don't fill that slot on the.
Right. Okay.
Yeah, there are specific slots for city council, for ledge, for nursing, for physician. But then we have like 5 at-large members and that's.
When we talked about trying to get younger people.
Yeah.
What was our barrier? Was it the time we were meeting? What, we talked about this, you know?
No, I think we had one nominee who was a younger person, but we haven't really had, I don't think anybody said anything against it. It's just that we haven't had a nominee that's younger.
But
Yeah.
I mean, I would think if we're assertively looking, or the way we do it is gonna be different for a younger person. And it could be, you know, somebody of age, you know, 18 is a lot younger than I am apparently right now. But I think, I don't know, it would be nice to have, but you know, once again, and this is some of our principles are coming around, when you bring one, you don't need to bring a second. I think it's very difficult to always, as somebody who's often been the only one, that is very hard, especially at a young age.
For sure.
Well, that's a nice segue to the other thing that we sort of wanted to talk about was, are there focuses that we wanna have? You know, to your point, like, should we focus on trying to get our youth to the board? You know, last time we talked about, you know, mental health piece, right? So, you know, some of the things we heard from the ledge was, you know, veterans, elderly,
Formerly
incarcerated folks. So that was the other thing I wanted to try to talk about for a few minutes if we were able to, is like, is there a focus that we wanna have? So I guess first, is there any comments on this language?
I think this looks good and I appreciate you all taking the time to write this.
Is there a little bit more about what we're supposed to do? I know we've confused ourselves.
Yeah, so there's actually,
There is.
the last nomination committee.
Yeah.
Wrote a fact sheet, which I actually think we should.
I wrote the fact sheet,
I'm
but
sorry.
they said it's a good idea.
Yes.
Not to say, but whatever.
For the fact sheet. I think we should include this, at least like a link to it. Ian, somehow, or
Yes.
have the actual thing.
Nope, I can have a little button that you can click
Okay.
and it'll open up the document.
Because to your point, it does have the time commitment.
And it's alluded to in the paragraph there on the
Yeah.
website, if I remember correctly, but all the details there, yeah.
I'm wondering too if there's other ways to share it. Right?
Well, typically, we take this out to our people and say, hey, you seem like you'd be great for the board. Now, there's a problem with that kind of nepotism, like you bringing more of your own, right, which
Right.
isn't great. But certainly, we all have large networks, so one would think we could share to our networks as well. But I don't know, is there a health department,
I can put it on the counties.
Insta
Yeah,
or anything?
especially when the press release goes out, I'll share that on all the counties,
Perfect.
health department, social media.
Yeah, that's great.
And could you send it to us
Look for it.
via email with the fact sheet?
Yeah, well, hopefully we're getting all the press releases, right?
Okay.
And for those who are unaware, the county has started putting out, county administration has started putting out, Megan, is it quarterly? Is it bi-monthly newsletter where they're just sharing like opportunities and information about all different parts of county government? So we could include it.
doing that monthly.
Oh, is it monthly? Okay. So it could maybe go out in that as well.
But again, I think this April 25th was just to give us like a week to review cover letters and resumes, so time is a little bit, I know, time is a little bit of the essence, so.
Yeah, I mean, I guess we're still pretty early in April, but maybe, I don't know.
30 seconds.
Yeah, I know. So maybe May, I mean, certainly we've been late with nominations before, and it takes the ledge a couple of months, even for you to get it and then to vote on it, et cetera, so that's why we're so in advance of the election. All right, so we'll see how long the press release, takes to get up and running. No pressure, Megan, but work on that.
Please
Any
and thank you.
language change to the paragraph?
I have a handful of things that I'll give to
Uh-oh.
Sarah.
Yeah.
Sorry,
Leave it to an
don't give me a copy and a pen.
It's not a red pen.
No.
is it?
It's actually blue, I
Yeah,
usually
that's
use
good.
green,
Yeah.
I usually use green for my markup, but I have blue instead.
He doesn't use red.
Yeah, blue's a lot nicer.
He knows red is traumatizing. He uses
I-
red.
Yeah, I don't use red.
Alright,
See all our documents.
Yeah.
So does the, oh, I'm sorry, is there more in the language? You guys are.
No, she just, she mentioned an EEO line.
Yeah,
great. The board accepts applications from anyone of, background, yeah.
And how many positions are you looking for?
Just one, but I think the idea was for us to have a rolling list of people. So that way people could always, we could always just,
We have a year coming up and it's not 25, it might be 26. Where like 6 people are coming off the board and that's a problem. So Brendan and I, one of these days, are gonna get together and talk
One of
about
these
plans
days,
for weeding off and on or whatever, but that's when this list will be great. We don't wanna at that moment say, okay, we need 20 people to review, so hopefully we have.
It may involve, asking the ledge to kind of like reset the classes so that we're actually cycling on and off, because in the prior administration and through COVID, the board appointments, it was a little bit off sync, and despite everybody's best intentions, so it's something the ledge has corrected before with regard to other boards, and it's something we could certainly consider.
All right, are there specific types of people, characteristics we would be interested in on the board?
I do like elders, like relatively young people.
Many of us qualify in that.
So I might be able to get another cycle on right after I get that, right?
And I wasn't clear if the comment from the legislator was that there were not veterans or just not veterans serving agencies represented, because clearly we have a vet, right?
It
And
was
so
brought up-
similarly, do we want a more senior representative in terms of age, or just agencies that tend to serve seniors to bring that perspective?
I'm really looking for the primary perspective. I feel like I'm at enough tables where the agencies.
Yeah.
I agree, Dr.
And that's one thing I missed with Bill and Joe coming off. They're
Yeah.
very not health related. Like, it was nice to see an outside perspective if you were.
and he went through that health stuff real quick, and I was
I
like,
know.
I'm not a health person, can you slow down?
Right, exactly, but I love that, I think that's like somebody who's not doctor, not nurse, not researcher, like somebody with a good solid perspective.
I was thinking about SACE, for instance, there's, it's a group of elders who learned about, research, and once again, I think the principle is, send somebody in alone.
Yeah.
Do we have any flexibility for the size of our board, or is it?
Well, anybody can attend a board meeting, so they could bring a friend, right? But to sit on the board, those numbers are set.
Yeah, I like all the ones you listed.
Yeah.
But
Older,
the formerly
younger,
incarcerated one kind of interests me as well.
Returning citizen.
Oh,
What is it?
Returning citizen.
returning citizens.
Make sure they have all the right.
Yeah.
If you have anyone who identified or
Can you say that louder? I'm sorry.
Sorry, I just was wondering if there's anyone that identifies as a person with a disability on the board.
Yeah, so I think diversity of thought for sure, and the things you said, maybe a younger person, maybe an older person.
So I guess when we're deciding, I mean, I think that we were gonna use the same process before, we get like their cover letter, letter of interest and
Yeah.
resume, and then we
Yeah.
kind of talk about them. But is it like, do we wanna do or wait if they're one from one of these groups, or does that kind of independently vote?
Yeah, I mean, we don't have a clear, scoring criteria. We certainly could develop something like that if we wanted. It's been fairly, general conversation. And we'll have to talk about what that looks like with the broadcasting, because obviously that would be a closed session.
Varies depending on how people interview as well.
Yeah.
Yeah, true. I did a great interview, very, cute. But that, that kind of influences your, at least it did me, you're thinking about, who and what you're representing and the importance. Some people are better at getting that across. Yeah. Not necessarily fair.
I think it's fair for us to give the nominations committee some like lanes or like potential opportunities, and we trust you guys to work through that and do those interviews, report back to us how you feeling with the.
So we're doing it.
Well, yeah, so. First of all, two things, no, you're okay. Two things, first of all, we didn't really have interviews, but we did invite our potential board members to a board meeting before they were assigned to the board, just to give them a flavor.
Yeah, listen, I didn't wanna say I was interviewed. I wasn't gonna announce it.
But to come here and just meet us and talk, which is fine. The second thing is, we don't use the nominations committee like most people use nominations committee, where they create a slate. Now, if you all want to do that, you are more than welcome. I don't know if 1, 2, or.
I mean, 10 fair,
people
I was gonna say, I don't think there's gonna be like 15 applications that like Aaron and I just don't. So I think it's like. if we are-
with social links and everything.
Yeah, I mean, this is gonna be bigger than we want.
You put it on Instagram, it's all.
I'll save you this.
Just email the.
That was the idea, yeah.
Yeah. Put them in a box and rank them in some way, yeah. And maybe we have a thing on the bottom, is this person young, is this person old, whatever, but
Yeah.
I don't know what the. Do you have any criteria? No. Okay, good, you're. Yeah, I guess that's.
I suggest that you wrap this conversation up.
Yeah, no, just to get diversity of thought, obviously, not trying to do any.
Period.
Plus minus.
Period.
Period. Diversity of thought, period. All right, is anybody interested in closing the meeting and want to propose?
One question for
Yes,
Mr.
yes.
for Albert.
Yeah.
What is going on with this committee? Did I miss it earlier? The health committee within the legislature?
Yeah, so great question. We're actually planning on talking about it at like 5:30. So I have the folks from the CART came and presented to the Democratic Caucus legislature about a month ago. And a subgroup of legislators wants to also look at the proposal and take it through. So it's on the agenda for tonight, although we have a bunch of other things on the agenda and things have gotten spicier in the last few weeks. So, yes, more conversations.
And thank you for that, because it reminds me that we were planning to bring the race commission back here, the CART maybe, back here to talk to the group. But we're trying to schedule Adam Bello if we can before we make any commitments to other people. And so Terry Lynn is with. Once we get dates together.
And I
thank
didn't know if the team were interested. I'm happy to meet with the CART just to update them on what we actually do and what the board actually does before having them come back to present to the entire board, because the last time we came, there was just a lot of, I think, misunderstanding and miscommunication. And so if I can clarify some of that ahead of time, I'm happy to do so, if you all would prefer.
they really feel that they are in a very different than we are, so.
I'm sorry, I think my internet was flaking out. Go ahead again, Linda.
Oh, it's me blinking out. I think I think they really feel that they're in a very different lane than we are in. So,
Getting on the same page would be a good idea.
well, I just think they don't think that this is similar to what they're looking to do.
I think Dr. Marty's point, and Marty, correct me if I'm wrong, is just the last time they presented, and I have the same recollection, is that they just had quite a number of factual misstatements about the work of the health department and the county as to public health, and it might be helpful to correct those misunderstandings
Yeah.
before they come back so that we can have a robust conversation.
Constructive use of everyone else's time, I would guess.
And they're certainly trying to do good work as we are. We just want to make
Yeah.
sure that we're doing and we understand what they're doing for sure.
Yeah, I mean, I remember with the raised commission, there was a lot of misunderstanding and I kept saying, there's this Board of Health, right? I'm on the Board of Health. And that wasn't really absorbed. There was definitely a feeling that the city didn't have any health support. You know, so anyways, I can't, because I'm not part of the CART. I did not, continue the work of Raise with the CART, but certainly I work with somebody who leads the CART, so
Yeah, I think we definitely need to work through some miscommunications, and Mari, I'm fine if you wanna do that. I'm happy to join you if you want me to. I'm happy to do that. I think eventually we'll want to just clear up some of that, just in a much more casual conversation than a full-on presentation in a meeting to come.
and the chair wasn't in it, if you recall.
The chair of
Thomas was not in
Oh,
it.
okay. That's true. All right, we are at 5 after. Anybody want to close the meeting?
Yes.
Great, Mike makes the motion, second. Great, all approved of closing the meeting. Everybody opposed? Wonderful, thank you guys so much. Appreciate all your work and your insights.